Hello, I'm Kate Sticka, and I am here to speak to you about the field of obstetrical pharmacology. I'm an associate professor in obstetrics and gynecology, as well as the medical director of the OB emergency room at Northwestern University. To give both an introduction to the field as well as myself, I'd like to just address some of the historical landmarks or highlights that have occurred in the field of obstetrical pharmacology within the last 2 decades. OB pharmacology is a relatively new field. It was only officially recognized by both the FDA and the NIH as a potential special population in the late 1990s. At that time, I was a part-time medical consultant for a pharmaceutical company, J.D. Searle in Chicago. And at that time, I convinced them to do one of the very first pharmacokinetic studies in pregnant women conducted by a pharmaceutical company, and the drug we did was metronidazole. At the same time, there were a series of conferences convened by the FDA and the NIH focusing on medication usage in pregnancy. And because of my role in this study working at Searle, I was an invited lecturer where I talked about conducting a pharmacokinetic study in pregnancy. As a result of that, I was also a co-editor of the first FDA guidance on the conduct of pharmacokinetic studies in pregnancy. And then in 2004, the NICHD began their obstetrical pharmacology research units where they funded programs to specifically study drugs in pregnancy. And for the next 10 years, I was on the Data Safety Management Committee. And then this past year, my institution with myself as one of the principal investigators, along with Kathy Wisner in psychiatry and Al George in pharmacogenetics, was awarded a 5-year grant to look at and explore the use of several antidepressants in pregnancy in moms with depression. I have no financial conflicts of interest, but I will definitely be talking about medication usage in pregnancy that is considered off-label, that is supported by the evidence in the literature, but not formally approved by the FDA. So the educational objectives I would like to accomplish during the next discussion is to explain why pregnancy is a special population with respect to its pharmacokinetics, to describe the changes in hormones, body water, renal clearance, and protein binding during pregnancy, and to understand how the primary PK changes that occur in pregnancy affect the amoxicillin and digoxin, and then to also look at how pregnancy affects the hepatic metabolism of other medications used in pregnancy. And I'll use some examples such as lamotrigine, dextromethorphan, and methadone to illustrate these points. And then I will explain why the net effect of pregnancy changes is not always predictable. These are a series of abbreviations you'll see that I use in my slides. And just as an overview, once again, I'm going to be talking about pregnant women as a special population. I'll be addressing the physiological changes that occur in pregnancy, and I will speak to each one of these points sequentially. So the first one that I'm going to be talking about is pregnant women as a special population. So what does special population mean? It's a group of patients in whom the pharmacokinetics differs from the standard healthy young adult sufficiently that dosing changes are required for either safety or efficacy of the medication. And recently, pregnancy has been added to the well-known list of renal disease, hepatic disease, pediatrics, and geriatrics. So when we're talking about pharmacokinetics, I think it's important to introduce this concentration time curve because I will be referring to this type of graph as well as the terms that we utilize in here. So on the y-axis, we have drug concentration. The drug is administered at 0.0. And then what you have is a series of concentrations that are drawn over time, and it gives you this very classic appearing curve where the area under the concentration curve is referred to as the AUC. We have a minimum effective concentration that occurs for each drug. It's different. Then you have the minimum toxic concentration, and this range in between is called the therapeutic range. Now, what if this is the curve of a drug for somebody who's non-pregnant? And in pregnancy, when we plot out the concentrations, we see a slightly different curve. Now the question is, do we have to change the dosing recommendations for that drug given these characteristics? Well, if this is the minimum effective concentration, it turns out very similar to a non-pregnant state. Most of the concentrations stay above that minimum effective concentration, just like they do for a non-pregnant person. And so in this situation, you're not going to have to change your recommendations. Using the same dosing recommendations for somebody who's non-pregnant, you can apply them to the pregnant person as well. However, if this is the minimum effective concentration, you'll see in pregnancy that almost all of those levels fall below. And in this situation, you will not be getting the effective, the effect that you want from administering that drug. So you have a choice, whether we give more drug, whether we change the frequency. So if this is what we see, so this is the non-pregnant curve, this is the curve in pregnancy, and you can see that it's clearly not lasting as long, and the levels aren't anywhere near as high. We have a choice. We can either give more of that drug, but in this particular situation, what might happen is that it actually puts you above the minimum toxic concentration, and you would there be faced with side effects of unwanted side effects. Alternatively, what you could do is you can change the dosing frequency and give the drug again in a shorter period of time and get the same duration of effect that you want in a much safer manner. So medications with a narrow therapeutic range where there's not much difference between the minimum effective concentration and the minimum toxic concentration. When medications are dosed too high, they may cause risks to the mom or the baby. And when underdosed, these medications may be associated with a different set of risks, inadequate treatment. So what I'll now address are some of the physiological changes that occur in pregnancy. I'm going to start off with the dramatic hormonal changes that occur. So let's speak to progesterone first. Progesterone is only produced in the woman of reproductive age during the luteal phase of her cycle, so just before and after ovulation occurs. And it typically can reach levels of 30 to 40 nanograms per mil. In term pregnancy, there's a dramatic increase up to 130 to 150 nanograms per mil. The increase in estrogens is even more dramatic. So in an average non-pregnant state over the course of a menstrual cycle, estradiol can really change from the low 30 picograms to as high as above 200 picograms. But let's say for an average, it's 50 picograms per mil in the pre-pregnancy or non-pregnant state. By the time you get to term, that number has gone from 50 picograms to as high as 25,000 picograms per mil of estradiol. And there's increases in the other estrogens as well, but this is a dramatic, huge increase in estrogen, making pregnancy a hyperestrogenic state. I'll next address the fluid changes that occur in pregnancy. To be very specific and blunt, pregnant women are wet. They're much wetter than a non-pregnant person in terms of total body water. This affects the volume of distribution for certain drugs. The volume of distribution, the definition is it's the volume in which the drug would need to be uniformly distributed in order to produce the observed blood concentration. And so the formula for it is the amount of drug that's been given to the body over the blood concentration. And you can kind of think about it is that if you put a drop of red food coloring in a cup of water, you have a certain concentration in that cup. But if you instead put that same drop into a gallon of water, the concentration would be remarkably different. Now, there are what we call hydrophilic medications, and the volume of distribution for the medications that like water and distribute to water can be up to total body water. In contrast, you have lipophilic, which are fat-liking medications, and the volume of distribution for those can be extremely large because the body fat actually has an extensive capacity to absorb medications. And although pregnant women absolutely gain some fat weight in pregnancy, it doesn't affect the volume of distribution for lipophilic drugs as profoundly as some of the changes we see in body water. So, what happens to volume of distribution for hydrophilic medications in pregnancy? Well, there is a dramatic increase in plasma volume. Women become wetter, they take on water. There is an increase of about 1,200 to 1,600 milliliters in plasma volume above the non-pregnant state, or an increase of approximately 40 to 50%. This peaks at about 32 weeks gestation, but the increase begins as early as 6 to 8 weeks gestation. There's an increase in plasma volume that's relative to fetal number, so that the plasma volume in women with triplets is almost double that in singletons. The increase in red blood cell volume lags a little bit behind the increase in blood volume, so there is a delusional anemia that occurs in all pregnant women. And this is a curve just kind of showing you those different changes. So this is a week's gestation along the x-axis, and you can see changes in plasma volume. That is the red curve here, and total blood volume is the green curve. And you can see how the red blood cell volume goes up, but it doesn't go up quite as much. So giving these numbers, this was a study that was done in pregnant women compared to their non-pregnant state. And if you look at the average 70 to 80 kilogram woman, you can see that there's an increase of from being non-pregnant to being pregnant of 37% in this particular situation. And you see corresponding increases in extracellular fluid as well as total body water. So what happens to renal clearance in pregnancy? Glomerular filtration rate is proportional to cardiac output. Cardiac output increases by 30 to 50%. The increase begins as early as 5 weeks. 50% of the increase in cardiac output occurs by 8 weeks. And like increases in plasma volume, it peaks at around 32 weeks. Cardiac output is equal to the ratio of, the equation of heart rate times stroke volume, and both heart rate and stroke volume increase in pregnancy. The renal blood flow increases in pregnancy, and as a result, GFR goes up. And this was a study that was done quite a while ago, and it was looking at, so postpartum is the non-pregnant state, and this is creatinine clearance, which is reflects glomerular filtration rate. And this is inulin is in blue, creatinine clearance is in orange, and they're very similar. But what you can see is that creatinine clearance goes up from about 120 to an average in pregnancy of around 160 to 180 milliliters per minute. This is an interesting study that was done because the woman was actually, they compared it to when she's lying on her back in the supine position, which is from an obstetrical standpoint, we don't do that anymore. We don't encourage women to lay on their backs because what happens is it compresses the inferior vena cava, this heavy uterus. It decreases cardiac return, and as a result, cardiac output goes down, GFR goes down, and creatinine clearance goes down considerably compared to a woman who's not on her back. So how do these changes in body water and renal clearance affect drug distribution and clearance? So this was a study that was done way back in 1977. And in fact, this was one of the very first studies looking at what happens to medications when they're given in pregnancy. And what they found using amoxicillin, they found that there was a significant decrease in the maximum concentration in pregnancy compared to non-pregnant. And there was also a significant decrease in that area under the curve in pregnancy compared to non-pregnant. Similarly, when you look at cephalosporins in pregnancy, there are also changes in clearance. So postpartum is the clearance of cefuroxime is 198. And in pregnancy, that clearance goes up to 282 milliliters per minute. What's interesting is that the half-life also goes down, but in this particular situation, there really wasn't that significant changes in volume of distribution The penicillins and cephalosporins are renally cleared, and because renal clearance goes up, the clearance of these medications also goes up. Another study was done looking at amoxicillin in pregnancy, and this was actually financed by the Department of Homeland Security because they were concerned in pregnancy whether we could adequately dose people with amoxicillin to effectively treat anthrax. And so what they found is looking at amoxicillin concentrations in the postpartum compared to the third and the second trimester is that there were remarkable decreases in the areas under the curve and the maximum concentrations during the second and third trimesters compared to postpartum. And what they saw is that elimination half-lives are shorter, renal clearance is increased, and then something called renal secretion is also increased. And what that is that if this is the renal tubular cell, and this is the blood vessel, with the amoxicillin, there are transporters, organic anion transporter polypeptides that move the drug from the mom's blood into the renal tubular cell and then eventually into the urine. However, there's another transporter that sits on this that pushes that drug back into the renal tubule and moves it from the urine back into mom. However, in pregnancy, progesterone decreases the transcription of this transporter by some unknown mechanism. And so what happens is we lose that ability to absorb the drug back out of the urine, and as a result, there's a net increase in flow from the mom into the urine, or a net increase in secretion of amoxicillin that aids in the clearance of amoxicillin. All of these have also had their effect in terms of some of the guidelines in how we dose cephalosporins in pregnancy. We commonly treat women with a cephalosporin before pregnancy to before cesarean section to prophylax against a infection associated with that procedure. Previously, we had only used 1 gram in women, and we gave it to them on call or just as they were going to the operating room. Studies were done that showed that the levels of cephalosporins in mom's tissue, as well as what was being transported to the infant through the umbilical cord, were inadequate to appropriately treat the bacteria we were worried about. And as a result, the recommendations have changed to now giving 2 grams for women who are less than 120 kilograms at 1 hour prior to incision. And we also found out that women who are obese actually have inadequate levels with this 2 gram dose. And for women who weigh more than 120 kilograms, we have to increase that dose to 3 grams an hour before incision. The next thing I'm going to address are regional blood flow changes that occur in pregnancy. So the placenta acts as a low resistance arterial venous shunt. It basically is a fast way of taking blood from the arteries and shifting it into the venous circulation, and it becomes almost like a black hole sink within the cardiovascular system. And it sucks up 20% of the total cardiac output. And as a result, it reduces the cardiac afterload. There is an increase in renal blood flow that we've talked about before. There's also an increase in skin blood flow. Pregnant women oftentimes feel, they have pulmonary erythema, their hands are red, their cheeks are flushed, that they generally feel warm. And that's because blood is being shunted to the skin to reduce the heat associated with the additional metabolism that's occurring within the placenta and the fetus. There's an increase in mammary blood flow, but not everything can go up. And so there is a corresponding decrease in skeletal muscle blood flow, which people think is often responsible for the cramps that women get in their calves or other muscles. And there's also a decrease in splanchnic or GI blood flow. As to what happens in the liver, that's a little bit controversial. There have been some studies that have suggested that liver blood flow increases, but there have also been contradictory studies as well. But this would certainly affect hepatic metabolism for some medications that are dependent upon changes in blood flow through the liver. One study that showed that there was a clear proportion of cardiac output difference. So this is the proportion of blood that goes to the liver in a non-pregnant woman. And that clearly goes down proportionately over pregnancy. But in terms of the actual blood flow in liters per minute, in this study, there was very little change. So we don't quite yet know clearly exactly what's happening within the liver in terms of blood flow. There are definite changes in protein binding in pregnancy. So why is protein binding important? Well, drug molecules that are bound to plasma proteins cannot leave the plasma and cannot exert a drug effect. It's only that free fraction, the portion of the drug that isn't stuck onto the protein, that can move in and out of the bloodstream. And this is the free fraction can exert its drug effect. And it's also that fraction that can either move into the liver and be metabolized or move through the kidney and be excreted. Drug that is bound to the plasma proteins is literally stuck and is inactive. Drug assays can either measure total drug, which is a combination of the free and bound, or the free fraction. However, measuring the free fraction is more expensive, and so for many drugs, we tend to measure total drug only. In pregnancy, though, that can sometimes be problematic, as I'll show, because of what happens to protein binding. So albumin significantly goes down in pregnancy. This is the postpartum concentration of albumin compared to albumin during pregnancy. And you can see that it's much lower. There is very little change in total protein, except in certain medical conditions. The alpha-1 acid glycoprotein is another plasma protein, and it binds to basic drugs, while albumin binds to acidic and neutral drugs. But alpha-1 acid glycoprotein is also significantly lower during pregnancy compared to postpartum. So how does this affect how we monitor drugs with a narrow therapeutic index in pregnancy? So this is just a slide showing two scenarios for the impact of protein binding. In this particular situation, this is non-pregnant, this is a hypothetical pregnant woman. And if you were measuring total drug, you would say, oh, total drug significantly went down. But in this situation, because protein binding has gone up, so the ratio between this fraction here compared to this fraction is much greater. There's much less drug bound to the protein. What actually happens in this situation is there's no change at all in total free drug. So this would be misrepresenting exactly how much drug is there for effective drug, for drug effect if we were measuring total drug. This is another situation where it appears that total drug doesn't change at all. But in this situation where the amount of drug bound to proteins has gone down, we actually have double the level of free drug available. So drugs with a narrow therapeutic index where it's potentially dangerous to have unrecognized increases in drug level, that are highly protein bound, it's critically important that we measure the free fraction, not the total drug. And a good example of this is in pregnancy for women who are hypothyroid, we traditionally measure the free T4, not total. Drug transporters are transmembrane proteins. They facilitate movement of drug across the membrane, either into or out of the cell. There are more than 400 in the human genome, and they're critically important in moving drug across epithelial surfaces, such as the intestine, the liver, the kidney, the blood-brain barrier, and the placenta. And they're either important of moving them into and across, or in certain situations, keeping them out from the other side. Some require ATP. They're active transporters. Others don't. They're just facilitative. Drug transporters, this is an image that's been designed to show drug transporters that are on the blood-brain barrier, within the liver, within the intestine, and the kidney. And I actually I wish this was a pentagon, because I would add a fifth side and add the placenta, because drug transporters within this placenta are critically important in getting nutrients across to the fetus, getting molecules that the fetus needs to get rid of back across and into the mom, as well as critically important in protecting the fetus from drugs that you would find in the mom's bloodstream. And we're going to talk about digoxin as an example of placental transporters. So fetal tachyarrhythmias occur in about 0.5% of all pregnancies. And this is an example of a fetus whose heart rate is beating away at an excessive rate, and it's in a flutter situation. Typically, the fetal heart rate is 120 to 160, but it can clearly get up to close to 200 or more in tachyarrhythmias. This is important because if untreated and present for an extended period of time, fetal tachyarrhythmias can lead to fetal cardiac failure, high drops, and fetal or neonatal demise. And DIG is the primary drug that we use to treat this. It slows the AV transmission and it decreases the ventricular rate. And we're actually giving the drug to the mom with the goal of treating the infant. However, the problem is it's very difficult to get therapeutic levels of DIG into the fetus. And when they've looked at what levels are present in the mom's blood compared to the fetus, we see that there's dramatic differences between the mom's DIG level and the umbilical cord DIG, and it can range anywhere between 1/10 to 90% of the mom's level, with it frequently being less than half. And sometimes the mom actually becomes DIG toxic as we're trying to get adequate DIG across to the fetus. So the question is, why are the fetal levels so disproportionately low? Initially, when they started studying the placenta was found to be rich in cytochrome P450 enzymes. And it was presumed that they were there to metabolize drugs or molecules that were in the mom, and as a way, as it tried to cross through the placenta and as a way of protecting the fetus. But it turned out that most of these cytochrome P450s there were involved in placental steroid production, and that the traditional drug metabolizing CYPs that belong to the families 1, 2, and 3 are only minimally present. Therefore, DIG is not being metabolized by the placenta. However, there are multiple drug efflux and influx transporters that play critical roles in moving molecules in and out and away from the fetus. So P-glycoprotein is the one that's responsible for keeping digoxin out of the fetus and in mom's circulation. It's a ATP binding cassette transporter. It's an efflux transporter. And what that means is it sits on this membrane that's facing the mom's blood. So it's on the placenta, but on the side that's facing the mom as opposed to the side that faces the fetus. And what happens is as drug tries to move across, the P-glycoprotein sitting here spits it back out into the mom's circulation. It binds to a large number of drugs, including DIG, and it's located, you find P-glycoprotein in the intestinal mucosa, in the liver, the kidney, on the blood-brain barrier, and in huge amounts on the placenta. And this is just a diagram showing the placental trophoblast and the fetal circulation being on this side, and maternal circulation. And this is just the beginning of our knowledge. There are multiple different transporters that move drug back out into maternal circulation, other ones that move it from mom across into the baby, as well as in this direction from the baby and across this way as well into the baby. And so placental transporters play an incredibly important role in movement of drug in and out or away from the fetus. The next thing I want to talk about are changes in hepatic metabolism because of the pregnancy that affect both phase 2 and phase 1 hepatic metabolism. So I'm going to be talking about glucuronidation, or phase 2, and I'm going to use as a representative medication Lamotrigine. Lamotrigine was developed in the 1990s, and it was and is used to treat both epilepsy as well as bipolar disease. And the very first time, and we thought a lot of women got put on Lamotrigine back in the 90s because it was considered to be much safer than the existing medications that we had to treat epilepsy. The problem is, very early on, in 1997, a study was done that showed that the plasma Lamotrigine levels were much lower in pregnancy. And the dose, in other words, the dose that we have to give to maintain the same plasma concentration, in other words, how much you have to increase that numerator as you try to keep the drug levels in the mom the same, turned out to be 3.6 times higher in the 3rd trimester and 5.8 times higher at delivery compared to postpartum. And this strongly suggested that there was enhanced clearance of Lamotrigine during pregnancy. So the studies that led up to our understanding switched from looking at pregnancy to looking at women who take both lamotrigine and birth control pills. And we found that lamotrigine levels are also reduced by more than 50% in women who are on combined birth control pills. And we tried to then tease out, so is it the estrogen component that's in the pill, or is it the progestin component? And we have a nice little system there, because birth control pills come either in combined, where you have both estrogen and progestin components to the pill, as well as progestin onlys. And what they found is that when you gave progestin only pills, it didn't change the lamotrigine concentrations at all. However, when you added estrogen, ethinyl estradiol, to the pill, you suddenly had lower lamotrigine levels or enhanced clearance of lamotrigine when women were on the estradiol as well as the progestin. So estrogen was required to increase lamotrigine clearance. So the question is, how does estradiol affect lamotrigine clearance? Well, you have to ask, how is lamotrigine cleared? And it's cleared by phase 2 hepatic metabolism. It's conjugated via N-glucuronidation followed by renal clearance. And what glucuronidation does is it takes these simple molecules that are in our body and attaches them to the drug. And whether they're sugars or sulfates or amino acids, things that are floating around in our body that are very common, we stick it on the drug to make it more water soluble. It's biotransformed so that it can then be renally cleared. And there are multiple different conjugation reactions, glucuronidation to either the oxygen, the nitrogen, or the sulfate, the sulfur in it. It can be sulfated, where you actually put a sulfate group, acetylated, methylated, or you can stick amino acids. All of these are different conjugation reactions that are catalyzed by different enzymes. For the lamotrigine, it's catalyzed by something called uridine 5-diphosphate glucuronylyl transferase that has 2 different subfamilies, and the particular enzyme within these families that glucuronidate lamotrigine is something called 1A4. And estradiol turns out to be a potent inducer of glucuronidation, mostly of 1A4, but to a lesser extent of 1A3. They did Chen in 2009 did a study where they looked at hepatocyte cell cultures and exposed them to different hormones. And it turns out uniquely that it was estradiol that upregulates the transcription of UGT1A4. And as a result, in the presence of estrogen, glucuronidation of lamotrigine is increased. So how quickly does the estradiol effect go away? Well, you can also study it easily with birth control pills, and what they found is that off week, birth control pills are given 3 weeks on, 1 week off, and during that off week, by day 3, when you take the estradiol, ethinyl estradiol away, by day 3, the levels of lamotrigine are 27% higher, by day 5, 63%, and by day 7, they're 116% higher compared to when the clearance was increased while they were on the birth control pills. So when you take away the ethinyl estradiol, lamotrigine levels rapidly rise during this placebo week. And because the induction of 1A4 by ethinyl estradiol quickly falls, women can actually become lamotrigine toxic by the end of that placebo week. Similarly, after delivery, lamotrigine levels rise very quickly, and as glucuronidation returns to normal, and the increased amount of drug that you've had to give this woman during pregnancy, you actually have to taper off by no more than 3 weeks after she's delivered. We're going to switch gears now and talk about phase 1. And phase 1 hepatic metabolism is the conversion of these drugs through a chemical modification into less toxic, or oftentimes less toxic metabolites. Sometimes our body actually turns them into active drugs. Sometimes it turns them into a metabolite that's just as active as the parent. But in terms of clearing the drugs, what we're talking about now is phase 1 metabolism, where it converts them into less toxic metabolites that can then be removed by the kidneys. The cytochrome P450 enzymes, there are 12 families. They're divided by amino acid homology. The ones that are involved with drug metabolisms are the CYPs1, 2, and 3 families. There are subfamilies based on even finer reducing their homology with an additional number if there's more than one subfamily. There is redundancy in the system to make the body safe. We've built an incredible amount of redundancy into it. More than one enzyme can catalyze the same reaction. Some drugs are metabolized by one enzyme. Many drugs are metabolized by multiple different enzymes. And pregnancy can affect the cytochrome P450 enzymes differently. And this is a chart showing some of the more common CYP enzymes and showing that some of them are increased, whereas, for example, 1A2 is decreased, 2C19 is decreased. And these are some of the representative medications that have been studied to help us understand what's happening to these enzymes in pregnancy. I'm going to be showing some representative drugs, medications in pregnancy to demonstrate some of these changes in the cytochrome P450s. Cytochrome P451A2 clears caffeine, and this is a chart showing the changes in clearance of caffeine. This is postpartum where clearance is high. In pregnancy, clearance of caffeine is decreased. And as a result, it's not uncommon for women to not like the effects of caffeine because it takes them much longer to clear that cup of coffee. It can linger throughout the day during pregnancy because the clearance is reduced. Cytochrome P453A family metabolizes more than 50% of the medications we use. This is just a representative list. Its activity was studied definitively by Mary Hebert in 2008 when she looked at midazolam. That's a probe marker for 3A activity. And she gave it both during the third trimester as well as 68 weeks postpartum. And what she found is activity of 3A4 enzyme goes up dramatically in pregnancy. And you can see this is the area under the concentration curve for the non-pregnant in pink. And during the third trimester, those concentrations and the clearance of midazolam are, the concentrations go down and the clearance is dramatically increased in pregnancy. 2D6 is an interesting enzyme. It is probably our second most active in terms of the numbers of drugs it metabolizes. And it's broken down into different metabolic phenotypes depending upon a person's genetic makeup. So if somebody has two active genes, they're considered an extensive metabolizer. But if they happen to have no functional gene at all for 2D6, they're called a poor metabolizer. There are people who are intermediate metabolizers where they have one active gene and one non-functional gene. And there are populations of people who have actually multiple copies of the active gene, and they are called ultra-rapid metabolizer because their activity of 2D6 is actually enhanced. The activity between these different phenotypes can vary by 1,000-fold. And what's important to know and to understand is that there's ethnic differences in these allelic prevalences. So whereas there are 5 to 10% of Caucasians are poor metabolizers for 2D6 and have no functional genes, that situation is actually uncommon in people of African, Asian, or South American descent. And ultra-rapid metabolizers, on the other hand, you find in East Africans, in Arabians, and Pacific Islanders, but you very uncommonly find it in Caucasians. So the way we differentiate these people is to look at how dextromethorphan is metabolized. So it can be metabolized by both 2D6 and 3A4, but it goes in two different directions. So the 2D6 puts it to is an O demethylation, whereas 3A4 is an N demethylation, and you can look at the presence of dextrofan to dextromethorphan as a measure of 2D6 activity. And what you see for this enzyme, this is the poor metabolizers. They're not able to, they're above the one line. They're not able to move dextromethorphan to dextrofan, and so the numerator is high, and that's where they're sitting, as opposed to the extensive metabolizers where you're able to convert dextromethorphan to dextrofan. It's not considered to be a classically inducible enzyme, so unlike some of the other ones, it doesn't get turned on, it doesn't get, its activity doesn't seem to go up in the typical situations where hepatic metabolism is increased. However, in pregnancy, oddly enough, the folk who are heterozygous extensive metabolizers or homozygous, it turns out that their conversion of dextromephorphan to dextrofan is actually increased in pregnancy, and the poor metabolizers have even a harder time, and their activity seems to go down. So this is in a unique situation that is not well understood as to why in most situations 2D6 is not induced, but in pregnancy its activity appears to go up. Methadone is the last drug that I'm going to be talking about in terms of its cytochrome P450 effect. It is metabolized by a combination of 3A4 and 2B6. It's not clear which one is dominant, but there can be lots of variations in people's ability to metabolize methadone. In general, though, what you see is back here are postpartum clearances of methadone, and compared to pregnancy, where clearance of methadone dramatically goes up, which means for the same amount of methadone a person is taking, their concentrations are going to be lower and they're not going to last as long. And this was borne out by a study that was done in 2013 with 25 pregnant women on methadone, and they looked at their trough to dose ratios during pregnancy and postpartum. All women required a dose escalation across pregnancy, and the elimination half-lives were about half of that reported in non-pregnant women. In other words, that the drug stayed around for a much shorter period of time, but they reverted back to normal with 1 to 2 weeks post-delivery. So the question becomes, it's easy to understand why volume of distribution changes, why glomerular filtration rate and renal clearance changes and protein binding. That all can be explained by a fairly common understanding of pregnancy physiology. But what is not well understood is why do these changes occur in hepatic metabolism and renal secretion and activity of the other transporters. And one of the hypotheses that's been proposed is utilizing a system called the xenobiotic sensing receptors. And they are receptors called pregnane X receptor and constitutive androstenedione receptor. That's a long name, or we commonly call it CAR and PXR. And what these receptors are, they evolved from primitive estrogen receptors that in early vertebrates were around they evolved into regulating bile acid metabolism, and they began to mutate and change into the current situation that we have now. We think they developed as a way of protecting the environment, protecting the organism from the phytoestrogens, the toxins that they found in its environment that could disrupt its endogenous steroid equilibrium, and as a way of ensuring reproduction. You ramped up the system when you were exposed to these medications, these drugs, these chemicals that came from plants, and to get rid of it so that the reproduction and the cycling of hormones in the female organism would not be interrupted and destroyed. And it turns out we utilize these same mechanisms to detoxify xenobiotics and transport and metabolize modern drugs. And the way it works is you have an enzyme-inducing drug in the environment. It crosses into the cell. It interfaces with PXR and CAR in the cytoplasm and the nuclear receptor. It then goes to the hormone-responsive element on the DNA. It forms this dimer. It then triggers transcription of the target gene, and then that target gene causes production of protein products, and which then serve as the drug metabolizing enzyme and the drug transporters. There are many drugs that bind to PXR and or CAR, and you can see that estrogens and progestins are two of those important drugs. The question is, what upregulates PXR and CAR? Is it simply the dramatic increases we see in progestin and progesterone and estrogen? Is this the mechanism that changes hepatic metabolism in pregnancy, or is it another independent mechanism? And the other question is, why are some cytochrome P450s downregulated in pregnancy? And all of this is not well understood. In summary, I just would like to say that pregnancy is considered a special population. The physiological changes that occur in pregnancy can profoundly affect drug distribution and clearance of some medications, requiring different dosing regimens to maintain both efficacy and safety. The changes that are observed in drug metabolism in pregnancy vary depending upon the enzymes involved for each medication. Fetal exposure to medication varies. The placenta plays an active role in shunting some drugs away from the fetus and allowing other drugs to cross, and it varies from woman to woman. Pharmacokinetics, the differences in drug metabolizing enzymes and drug transporters, can affect both how an individual person responds and the extent of fetal exposure to different medications. Significant progress has been made in the past 10 to 15 years, but our understanding is just beginning and we have a long way to go. I would like to thank you for your attention. I hope you've enjoyed my presentation on obstetrical pharmacology, and I hope it'll give you the wisdom to look at drug usage in pregnancy with a different light.